welcome to OsteoBites. Thanks for taking time out of your day to join us. We'll give a couple seconds for everyone to get settled into our virtual room. So excited to have you here and really excited about our guest today. My name is Christina Iptoma, and I am mom to OsteoAngel Dylan and Director of Scientific Programs at MIB Agents. And today on OsteoBites, we are joined by Dr. Brigitte Brisson from Ontario Veterinary College at the University of Guelph to discuss magnetic resonance guided high intensity focused ultrasound for palliation of canine appendicular osteosarcoma. Thank you so much, Dr. Brisson, for joining us on OsteoBites today. We are thrilled to have you. And thank you also to our panelists, Max, for joining us. Everyone, please feel free to submit questions during the presentation through the Q&A in Zoom, and we will share those with Dr. Brisson. And then a little bit more about our guest today. Dr. Brigitte Brisson is a professor of soft tissue surgery in the Department of Clinical Studies at the Ontario Veterinary College, and she graduated from the Faculté de Médecine Vétérinaire at the University of Montreal in 1996. She performed a small animal rotating internship at the Ontario Veterinary College, followed by a surgery residency with a concurrent Doctor of Veterinary Science in small animal surgery. And she became board certified in small animal surgery in 2001 and has since been on faculty at the Ontario Veterinary College. She is an ACVS founding fellow in minimally invasive surgery and a founding member of Veterinary Neurosurgical Society. And her clinical interest is in soft tissue surgery, including oncology and neurosurgery, with a specific interest for minimally invasive and interventional procedures. Dr. Brisson's research is focused on canine invertebral disc disease, innovative minimally invasive and interventional surgical procedures, and osteosarcoma. She is currently collaborating with a group of pediatric surgeons and interventionalists to develop novel treatment options for canine and pediatric cancers. And Dr. Brisson has been invited to present the results of her research and other CE around the world, and has published over 70 articles in refereed journals, authored several book chapters, and is a co-editor of Wiley's Current Techniques in Canines and Feline Neurosurgery textbook. Thank you so much for joining us today, Dr. Brisson. We are very much looking forward to your talk. And just a couple of quick announcements before we get started. We are 9 days away from September, so we are getting ready for Childhood Cancer Awareness Month, and you can order a gold bow to proudly display on your mailbox, front door, or anywhere special. With just a $25 donation, you'll receive a bright, beautiful, and highly weather-resistant gold bow, which is a symbol of hope, love, and solidarity for families facing childhood cancer. We have dedicated bow agent volunteers who are starting to deliver gold bows in their neighborhoods nationwide. You can also just order one directly from our website if you don't have a bow agent near you. And I will put some more info in the chat about how to order or find a bow agent in your area. And whenever we have an episode featuring work on canine osteosarcoma, I always like to highlight our canine clinical trials resource that we have on our website. It provides information and resources on participating in canine trials, as well as a directory of veterinary oncology programs and open canine osteosarcoma trials, including this study that Dr. Brisson will be discussing today. So I'll put a link to that in the chat as well. And also, we do have a comparative oncology playlist on our YouTube channel where you can find past webinars discussing canine osteosarcoma studies. So I will also put a link to that in the chat. Max, could you go ahead and introduce yourself?
Hi, my name is Max. I was diagnosed with osteosarcoma in my right femur in 2015 when I was 10 years old. Since then, I've been 8 years NED and have been involved with MIB as an ambassador agent and as a junior advisory member. Now I'll hand it over to Dr. Brisson.
Thank you so much. I'll share my slides. This work?
That looks great.
Okay, perfect. Oops, my screen is a bit funky here. Okay, so thank you, Christina, for the kind introduction and for inviting me to present this exciting research. It's a real pleasure to be here today, and thanks, Max, for attending as well. As Christina mentioned, I will be discussing osteosarcoma in dogs and presenting information regarding a study that is ongoing, assessing the use of high-intensity focused ultrasound for palliation of limb osteosarcoma in dogs. Okay, so osteosarcoma is the most common primary bone tumor in dogs and children, making dogs a unique naturally occurring bone tumor model for translational research. Dogs live in the same environment as humans. They develop osteosarcoma naturally. Treatments for osteosarcoma are similar for dogs and people. And given the lifespan and course of disease for dogs that is shorter than for humans, it allows for studies to be completed more quickly. Canine osteosarcoma mostly affects older, large, and giant breed dogs. It affects any bone, but it tends to occur most commonly in long bones, especially the distal radius, proximal humerus, and the femur and tibia. Like its human counterpart, it's an invasive and aggressive cancer that destroys bone locally and has a high rate of metastasis, which occurs mostly in the lungs. While less than 15% of dogs have evidence of metastasis at the time of diagnosis, the majority of patients will develop metastasis within 1 year, despite amputation for control of the primary tumor, and then follow-up chemotherapy, which suggests that the presence of micrometastasis exists at the time of diagnosis. And this is certainly supported by the fact that dogs appear to have high levels of circulating tumor cells in their blood. Circulating tumor cells are released from the primary tumor and travel through the bloodstream and can invade distant tissues to form metastases, but they can also stay dormant for long periods of time and escape diagnosis using even the most advanced imaging techniques like CT scanning, for example. In studies performed by our group, we determined that dogs appeared to have high levels of CTCs in their blood, and these persisted even after amputation and the start of chemotherapy, which really suggested that they had other foci of tumor cells in their body, even if we couldn't diagnose them on advanced imaging. Interestingly, though, the CTC levels remained low in long-term survivors, and they tended to spike a few months prior to us being able to detect metastases on lung X-rays. Regardless of the origin, whether it's primary or metastatic, bone tumors cause pain and reduce mobility, affecting quality of life and leads to loss of bone integrity that can then lead to pathologic fracture. Although we aim for curative intent treatment, in dogs, the main goal of treatment is to eradicate the primary tumor to reduce spread and provide rapid and durable pain relief that increases quality of life and slows metastases. We slow metastases then through chemotherapy. As mentioned previously, it's assumed that the vast majority of patients have micrometastasis, even if we can't document it on advanced imaging. So in dogs, our standard of care therapy for limb osteosarcoma is amputation, which is well tolerated by most dogs. It completely removes the primary tumor and provides excellent quality of life. It's then followed by chemotherapy to control metastatic disease and increase survival times. Although limb-sparing surgery is an alternative to amputation in dogs as well, amputation is the fastest, most reliable, and most predictable way to end bone pain, and it minimizes complications related to surgery, and then prevents the development of pathologic fracture. Despite all our best efforts, dogs with long bone osteosarcoma will almost certainly be lost to the disease, either from the primary tumor causing uncontrollable pain or fracture, or secondary to metastatic disease that affects quality of life and leads to euthanasia. So even when aggressive standard of care treatment is sought through primary tumor control with amputation and then chemotherapy, the median survival times of 1 year are really mostly reported, with only 20% of patients alive at 2 years. So there's a need for alternative palliative treatment options in dogs, since patients with severe osteoarthritis or neurologic deficits affecting other limbs, or if they've undergone an amputation previously and are not therefore a candidate for another amputation, these dogs need to have more options for treatment. More importantly, some dog owners and their families are just not ready or willing to go ahead with amputation with their pet. So when amputation isn't an option, then palliation of pain is the main goal, and this is currently provided through medical pain management and in some cases through palliative intent radiation therapy. Prognosis for medical management is on average 2 months, and for radiation on average 6 months, with animals typically being euthanized due to progression of uncontrollable pain or pathologic fracture. In addition, not all patients experience pain relief following palliative radiation therapy, and the treatment modality may be contraindicated, say if they have evidence of an imminent fracture in their bone. And then there are reports that indicate that really limb amputation may result alone, even alone, may result in longer survivals than with radiation. So the overall prognosis for dogs with limb osteosarcoma is grave, and similarly to children, it hasn't changed for decades, suggesting the need for additional treatment options to be discovered. And this includes providing additional options for animals where amputation is not readily available. Because pets who don't undergo amputation are ultimately euthanized for pain or fracture at the primary site. And those who undergo amputation without chemotherapy have a similar prognosis than dogs who do not undergo amputation. So this leads me to talk about image-guided tumor ablation techniques. These include chemical ablation, so things like ethanol or alcohol ablation, cryotherapy, radiofrequency ablation, and microwave ablation. All of these require a probe or a needle to be inserted in the tumor. So although they are considered minimally invasive, they are not completely minimally invasive. HIFU, however, similarly to radiation, is completely non-invasive because the transducer used for treatment is located outside of the patient, and we just go percutaneously to treat the tumor. So high intensity focused ultrasound, which I'll refer to as HIFU, is the only non-invasive percutaneous thermal ablation technique, and it allows deep treatment with precise control over the shape and the location of where the energy is being deposited. It causes minimal collateral damage. It can be used to treat primary and metastatic tumors, mostly with the goal of ablating or burning tumor cells and producing denervation of the surrounding bone and mostly periosteum, which causes a lot of the pain in patients. Since this method allows efficient heating of bone structures, it has found not only early use in the treatment of bone pain, but also in local treatment of malignant bone tumors, but mostly for metastatic tumors at this time. In addition to its role in tumor ablation, HIFU has attracted attention for its potential to stimulate the immune system and possibly mount a response against metastasis, which is referred to as an abscopal effect, and I'll talk about that a little bit more shortly. Finally, HIFU is also of interest for targeted embolization, so treatment of potentially abnormal vessels or trying to close down vessels that maybe supply an area that it shouldn't, and then targeted chemotherapy, where chemotherapy can be administered locally and then activated with the heat, and this allows for less complications, less systemic chemotherapy, higher doses, and less systemic exposure. So an abscopal effect is defined as the ability of localized treatment to initiate an anti-tumor response that kills cells in a distant site. So you treat something maybe in a limb, and then the immune response that develops would potentially suppress the cells that are distant, so micrometastases potentially, or even metastases that are visible. HIFU is believed to initiate an abscopal effect that can suppress growth or lead to regression of metastatic lesions by killing tumor cells and leaving them in the patient, and then the immune system mounting the immune reaction against it. So with local control and suppression of metastatic or potential suppression of metastatic lesions, there's hope that HIFU could become a potential treatment modality, or at least an adjuvant treatment modality for osteosarcoma. As the name might suggest, HIFU uses ultrasound waves to kill tumor cells. You might wonder how that's possible, given most of us have had diagnostic ultrasounds and it didn't lead to excess tissue death in our bodies, thankfully. So as seen in the schematic with HIFU, the ultrasound waves are focused by the transducer, and then they'll become very, very intense in one focal area. This area is usually converges onto an ellipsoid or sort of a rice or cigar-shaped focal zone. It can be as little as 1 to 2 millimeters in diameter by 8 to 10 millimeters in length, but it can also be made wider or longer, depending on the area of treatment desired. This is similar to burning a leaf by focusing sunlight through a magnifying glass. The energy absorbed by the tissues in the focal zone results in a rapid rise in temperature, hopefully above 56 degrees Celsius, which is that threshold for coagulative necrosis to occur. And by this, then we can kill those tissues. When possible, the goal is to treat the entire tumor and hopefully a small rim of normal tissue around it to get a margin, and then saving unaffected tissues and important structures like major vessels or nerves. One potential challenge when looking to treat bone tumors with HIFU is that ultrasound waves don't penetrate normal bone and would either be absorbed by the bone, as you can see here on the left side of this graphic, or it may even reflect the heat back to other tissues and potentially the skin, which could cause unwanted burns. The good news, if we can call it that, is that when there's a bone tumor, like an osteosarcoma, then the bone is generally gone, a little bit like what we see here on the right. Because the bone is destroyed, then that gives a window for us to treat the soft tissue tumor that is behind, or the bony tumor that's behind. Ultrasound or MRI is typically used to guide HIFU treatment. And this ultrasound guidance can provide the benefit of verifying the acoustic window. So we're treating with ultrasounds. If we can see the tumor with our probe with the ultrasound, then that tells us that, yes, this tissue would be viable for treatment. However, it's not as good for giving us details of anatomy or of tissue that have been treated. MRI is unable to confirm the acoustic window, but it gives us great anatomic detail and resolution. So it can be fabulous for treatment planning, and it will show us areas that may be too bony for us to treat versus areas that are less bony for us to treat. I'm sorry, I have a little assistant here. MRI is also good for intra-procedural evaluation, so to see whether or not our treatment is working and if we are progressing well. The greatest advantage of MRI-guided HIFU is that it allows real-time temperature mapping. This is known as thermometry, and it ensures we reach appropriate treatment temperatures. So we want to reach that 56 or more degrees Celsius, and it helps us monitor for inadvertent heating in collateral tissues that we do not want to heat and end up with complications. And then finally, newer systems like the one we're recently using allow us to cool the skin continuously while we treat, which again reduces the risk that we injure skin inadvertently. So thermometry calculates and displays temperatures during treatment, and it offers a superimposed representation of the temperature map over the anatomic image with a temperature accuracy of about 1 degree Celsius. This allows the team to stop treatment if unintended tissue damage appears to be occurring. So on this sort of screen video, it's kind of a screen grab of one single treatment. So where we have a cell that's being treated, so an area of treatment. I'm going to see if I can find a pointer. I can't here. So this area here where we see the red, so this was our area of intended treatment, and we're seeing these beautiful bright orange and red colors. This is what we want to see. We want to see the tissue, the tumor tissue burning, but we like to see this beautiful blue rim around that area. So the gray images are sort of our baseline images, and then all the different planes of our limb tumor, and then this map that occurs while we treat. And if we start seeing red in an area that's not wanted, then we can press the stop button immediately. The goal of HIFU is to treat several cigar-shaped areas known as cells using a chosen energy, and then to treat in a confluent pattern. So we try to treat the entire area. So this is a dog we treated recently. You can see different size cells that we used. So we can vary that depending on the results that we're getting and how safe we feel treating larger areas. And these, they look circular, but they are really ellipsoid. So if we see in the other plane, they are cigar shaped. So they may be 8 by 20 or 4 by 8 millimeters. And we try to treat as much as possible within the area that we have access to, which is the area that is in contact with our gel pad, and then without causing any collateral damage. Treatment challenges that we've found, especially in dogs, include poor contact between the tumor and the gel pad, which can limit the treatment window by interposing air between the tissues and the beam. You can see here we have a dog that we treated The dog is sort of on its side. We're trying to twist the limb a little bit to get this tumor to be in contact with the gel pad, and we want as much contact as possible. And here to the right, it's the MRI image of what contact we've managed to obtain, and then sort of the beam of our HIFU and which angles we could maybe obtain. And so we can't possibly treat anything in this region because there's black, there's air in between, so that would not be feasible. So in that case, we would try to reposition the patient if we want to do any more treatments in that area. We use degas gel between the tissues and the gel pad to try and get even more contact. And we also clip the skin in patients so that there's no air that gets trapped in the hair and could cause more skin burns or prevent our treatment. As mentioned previously, the waves don't penetrate normal bone, so the window of treatment may be limited in areas where there's a lot of mineralized bone remaining or potentially tumor mineralized bone as well. And then the depth of treatment is not always feasible depending on the size of the tumor. And we certainly see some of these patients with quite advanced tumors. And if they're too big, we just can't treat very deep. And some of these limitations would increase potentially our risk for skin burns. Finally, long treatment times can be a bit of a challenge. We have to image and then we have to position and potentially reposition a couple of times and then start our treatment. And then between each sonication or heat burn, we have to have a time of rest where we let the tissues cool down before we heat again in another region. But thankfully, our patients are usually pretty healthy otherwise, and they handle the anesthesia very well. So in humans, HIFU has been used for ablation of a variety of mostly soft tissue tumors, including uterine fibromas and prostate cancer, and most recently in bone applications, including non-spine or non-skull metastatic lesions from a variety of tumors, and then osteoid osteoma, which is a benign but very painful bone tumor that commonly occurs in the long bones of children and adolescents and can be quite debilitating. This is an example of a HIFU being used to treat an osteoid osteoma in an adolescent here. These require typically very few treatment shots. Other reported bone applications include bone metastasis and even osteosarcoma, and these are sort of the main references out there for osteosarcoma currently. On the left here is a figure from the Chen et al. Paper that's listed at the top, and it shows a contrast-enhanced MRI image of a highly vascular tibial osteosarcoma lesion. And on the right, it shows that same lesion that is no longer contrast-enhancing 36 months post-treatment. So although HIFU has been shown to be safe and effective in some human osteosarcoma cases like this one, it's currently not the recommended alternative to curative intent treatment, since early and complete removal of the tumor followed by chemotherapy is the treatment of choice and is associated with the best outcome. HIFU, however, could represent a non-invasive limb salvage option for patients with primary bone tumors who aren't a surgical candidate or who refuse surgery, and could otherwise be eventually considered for recurrence or non-surgical metastatic bone lesions or as an adjuvant to surgery, potentially. In veterinary medicine, the use of HIFU ablation has been described in the treatment of a handful of canine tumors, including skin tumors such as soft tissue sarcomas, liver tumors, urinary tumors, and then some folks have treated osteosarcoma, but usually only using ultrasound guidance. So reported adverse effects following HIFU treatment for a variety of tumors include pain, usually during the treatment. And so either local blocks are done if the patient is awake or some degree of sedation, and sometimes general anesthesia is required. And certainly in dogs, we place all patients under anesthesia so that they are easily treated. Swelling and increased pain postoperatively is reported in people and children, even with osteoid osteoma, where they are initially a little bit more painful, and then within 3 days to a week, maybe up to 2 weeks, then their pain subsides and they seem to recover from any pain. Skin burns, which occur rarely if you use a cooling system, but they certainly can occur. And finally, nerve and vessel damages have been also reported. This review of 20 years of published studies investigating the use of HIFU for treatment of bone malignancies, and this is mostly metastasis, concluded that HIFU is a very efficient method for rapid pain relief and can provide local tumor control if that's the desired outcome, and has a very patient-friendly safety profile as well. So it's encouraging. So on the basis of all this, and the hope that we can help both dogs and children, dogs who are not candidates for amputation and children with new treatment options, we're currently enrolling in the following pilot HIFU clinical trial mentioned previously. So our objectives are to determine if MR-guided HIFU, so MRI-guided HIFU can successfully ablate or kill canine appendicular or limb osteosarcoma, and whether it can palliate pain in dogs. We're also looking to document any complications that happen and to report on time to metastasis in these patients to see if we can get a feel for a potential abscopal effect in dogs as well. But this obviously will be difficult to document in a small number of patients. This study is a collaboration with the Polson Center for Image-Guided Innovation and Therapeutic Intervention at Toronto's Hospital for Sick Children. And this list represents only a few of our amazing collaborators and co-investigators that make this study possible. So dogs with confirmed osteosarcoma or long bone osteosarcoma, where owners decline standard of care amputation and chemotherapy, are eligible for this study. We do consider also dogs whose owners are willing to do or want to pursue amputation and chemotherapy, but would like to try HIFU first. Dogs with metastases and those that underwent radiation or have received biphosphonates are excluded at the moment. After HIFU treatment, dogs are still eligible for amputation if HIFU treatment either didn't work, or if the owners changed their mind, or if a dog developed a pathologic fracture, then they would still be eligible for that. And they can get chemotherapy, but not biphosphonates. Since the study is still ongoing and we therefore don't have concrete results to share, I'll present a couple of patients that we've treated thus far. So patient one was a 9-year-old Labradoodle named George. He presented with a distal radius osteosarcoma that was not suitable candidate for amputation. So this is him, and this is his tumor here, and we can see it radiographically. It's kind of more of a prolific rather than lytic tumor in his case, but it was diagnosed as osteosarcoma. And he had some arthritis and some knee issues, and so his owners felt that he was not a great candidate for amputation. Prior to HIFU treatment, he had been treated with medical management for his pain, and he had developed 4 out of 6 lameness, which is pretty significant for a dog, and then was no longer responsive to medical management. So the owners were interested. Interestingly enough, the one owner was a human orthopedic surgeon, and they were very excited to be part of this study. So under general anesthesia, we performed 3D MRI scans for treatment planning. And this is him in the tube there and some of the images that we obtained of his tumor. And I showed you some of these earlier. So it took a couple tries to get a pretty good contact with our pad and make sure that there's no air bubbles between the pad and the tissues, because that would reflect our heat and potentially lead to burns. I showed you these earlier as well. This is the HIFU or the transducer, which is within a hole within the table. So literally we lie the patient on the table, the transducer is under the table, and through this window, which we cover with a gel pad, then the ultrasound waves are concentrated at the area of treatment. And then this is how we see sort of our transducer, the lesion, and what areas are available for us to treat. And then we reposition if we feel that that's not good enough at the time. We add some degas gel around everything, and then we pack the patient up with some warming blankets, and we push them into the tube. It can be difficult to position them sometimes, and if they're a large dog and we position the tumor really well, sometimes they end up just not fitting in the tube, so that can be challenging as well. And then we try to cool things down during the treatment. So for George, our first patient, we performed 13 20-second HIFU sonications. So 13 little cells here. We went with small cells. It was our first patient. We were a little bit cautious with how much we could treat. So you can see they're circular in one plane and ellipsoid in the other. And we obtained these beautiful heating maps, our thermometry maps, that showed really good treatment at our intended site, a little bit of the tissues around it, which is great because then we end up heating more than what we even wanted. So it gives us more confluent treatment while keeping our skin surface nice and cold, which is great. And so for him, everything seemed to go pretty well. Things took a while though, so we only did a few of those treatments, 13, and then we woke him up. And this was him waiting for his parents to come pick him up. And he was very, very comfortable. We had done biopsies on his limb, so he had a little bandage, probably more comfortable definitely than before surgery, but that was likely due to all the medications he was on at that time. So the next day, as predicted by the literature and what's reported in people, he was much sore in his leg and feeling a little bit more sorry for himself. But you can see that, like what the literature says and what people report, within 3 days, he was walking actually quite well on that leg. And then his mom sent me this video at day 5 of him running in the beaches, and I just about fell over because I was so concerned about him fracturing his leg. At 15 days, we rechecked his tumor, and this is what we could see. We could see that area that we had treated. We kind of expected that it wasn't a very big area and that we weren't able to get very deep into his tumor, but clearly for him, it worked really well. He was able to walk without lameness. He was extremely comfortable. And so the thought was that just by killing a portion of it, we reduced some of that stretching of his periosteum, denervated part of it, reduced some of that pressure, and made him more comfortable. But this illustrates how limited our window was with him in terms of positioning. So the tumor above and below our site of treatment was not really affected. Clinically, we could see a divot that developed in the middle area where we treated. And although he did great for just over 100 days, at about 105 days, his parents said, you know, he's starting to have not really a lameness, but he seems just a little off. And we're seeing that the tumor above the treated area and below the treated area seems to be growing. So they asked if we could do another treatment. He still showed no signs of metastasis in his lungs, so we went ahead and did a second treatment. We were a bit more aggressive this time. His owners had mentioned that this was the last treatment for him. They really wanted us to be as aggressive as we could be. So we managed to give him 41 sonications at that treatment. Everything seemed to go quite well, and he was discharged with barely any lameness this time, so he didn't seem to be set back at all by this. Unfortunately, after a few days, there was evidence of a skin burn, which in hindsight, analyzing some of our thermometry maps, we could see that there was one area in a couple of shots where we seemed to have reflection of heat from some of the bone tissue in the area. And this burn kind of grew just a little bit and then sort of lasted a few days. The owners, being a surgeon, they managed this at home. And at 30 days, when we finally saw him, it was ready to be closed. So we just stapled it with him just under sedation, and he healed just fine. And he was still doing great at that time. So the owners were happy, he was happy, everyone was happy. Unfortunately, 72 days after his second treatment, or 177 days after his first treatment, he developed an acute swelling in another limb, so in his back leg. The swelling, unfortunately, was consistent with bacterial cellulitis. He had an abscess under his skin, and the owners declined surgical debridement at that time. They felt that he had osteosarcoma. Ultimately, his prognosis was really not great, and they decided to euthanize him at that time. On postmortem examination, it confirmed that he did have a cellulitis, and this was considered unrelated to the osteosarcoma. And he had a confirmed osteosarcoma in the right radius, which we knew already. There was a lot of regionally extensive fibrosis and osteolysis and reactive bone that was suggestive of the previous HIFU treatment being successful. And there were still some live clusters of tumor cells as well, especially in the distal area, so below the tumor where we had difficulty treating because of the angles. good news, I guess, there was no evidence of gross or micrometastasis in any of the organs, which is pretty impressive 8 months after diagnosis for a dog. So to wrap it up, I'm going to briefly introduce OJ, which is a 7.5-year-old Rottweiler. He is our most recent patient in this study. He too presented for distal radius osteosarcoma. His affected the left limb. And you can see it here. He has a little scab on it from where he had a biopsy prior to coming to see us, and that's him. So he's a big boy, and he has arthritis in essentially all his limbs. So he's quite lame in all limbs and therefore is not a candidate, unfortunately, for amputation. This is his tumor. So compared to what we saw in George, his is much more lytic. You can see there's a lot of void there in his distal radius. And this is what it looks like on a CT reconstruction, where you can really see that crater that the tumor has developed. And on CT, there's barely anything here in the metaphysis. And unfortunately for him, he also has a major fissure, which is sort of the beginning of a fracture that extends into his joint. So he would not be a candidate for radiation really with that. And theoretically, not necessarily the best candidate for HIFU either. But his owners are really committed and really wanted to go ahead. And so we thought, well, we can see if we can bring some new bone and healing to that area, despite that fissure that's very concerning. So despite all this, we did treat him. This is him on the MRI table and the HIFU table, and we treated him 7 weeks ago. He did very well. He is still lame, but it's quite hard for us to tell where he's lame from, if it's from his elbows or his shoulder or his fissure in his bone, and he's lame in all his limbs, so it makes it quite difficult to assess, but he seems much more comfortable around his tumor, and certainly the tumor has shrunk grossly as well. So for him, we use this new system that allows us to cool the skin down, so much less risk of burns. And we managed to treat him with approximately 30 cells on his first treatment. So you can see this is the image I showed you earlier, but sort of that confluent treatment of cells overlapping. And this is sort of in 3D, obviously, to get the tumor through and through. We use cells of various sizes to try and really reach the most bone tumor as we could in that treatment. And he's doing well. As I said, he's not perfectly sound like George was, but he's certainly doing better than he was preoperatively. And at 1 month post treatment, when we CT'd his limb again, his fissure had not progressed. So it had not started to heal, but it's pretty amazing that it hadn't progressed for him at that time. And like I said, he's 7 weeks post at this point and feeling really good. So clinical considerations based on our results so far. Again, we can't make any conclusions regarding our hypotheses, but still our preliminary results do suggest that HIFU can ablate canine osteosarcoma lesions. So we have lots of histopathologic evidence of tumor tissue being destroyed initially by coagulative necrosis and then being remodeled, which is a good sign because it's shown in people that bone can actually regrow and strengthen, which would be good for preventing fractures, hopefully, in our patients who need to keep their limbs. We're not sure at this time if curative intent treatment would be an option for these patients, and certainly we still recommend the standard of care of amputation and chemotherapy whenever possible if the owners are willing. And for us, we're aiming to treat as large an area as possible within the safe window for the moment as we do this study. It's likely the patient selection will affect our outcomes, given tumor size and location may affect the ability to treat soft tissue tumors. And like I said, our patients do come to us sometimes quite late in the course of disease, unfortunately. So their tumor may be too big for us to treat or too advanced or potentially have undergone pathologic fracture already. But we have high hopes for this modality to help dogs and possibly children in the future. So I'd like to acknowledge Pet Trust and other donors for funding this study and the wonderful group of collaborators that I work with at Sick Kids Hospital, their sponsors, and of course our patients and their families for trusting us with their care. I would also like to sincerely thank Christina Iptoma and the MIB Agents and OsteoBites family for inviting me to present this research today. Thank you. And I'd be happy to answer any questions the panel or the attendees might have at this point. Thanks.
So there's just a question in the Q&A that I can read. So it says, how did the results vary by histologic subtype, since it probably is more effective in lytic disease? How do you determine that the treated bone has sufficient strength to avoid pathologic fracture after treatment? When might you use the percussionist crematation of the defect after HIFU? How long does it take to do 30 cells?
Okay, I don't know if I can see the chat to see. Oh, I see there. Okay. No, I don't see the questions. Okay, so the first question was, would it be more effective in a lytic versus a prolific tumor? So far, we've treated dogs with both the sort of prolific or the more lytic. Definitely the more lytic tumors scare us more for fracture. The owners understand that their dog is at risk for fracture at any moment. It was when it walked in, and now with treatment, certainly we're treating an abnormal area, and so we're not aiming to damage any of the remaining structural bones. So hopefully we don't damage any of the bone that is still important at the moment. The tumors, whether they're lytic or prolific, oftentimes when we biopsy them, it feels a little bit cheesy. It's kind of soft and not even if it looks mineralized on the imaging. And we have seen a good ability to treat whether they were prolific, sort of more bony or more lytic so far. But again, in dogs like George, where we had more of a periosteal reaction versus a lytic lesion, we weren't able to treat as deep. So we would be looking currently at doing longer treatments or going ahead and doing more treatments in time. A treatment of, was it the 40 cells or 30 cells? It really depends. So each treatment is 20 seconds. And then typically we aim to wait about 5 minutes between each treatment. So once we've anesthetized, clipped, and shaved, and then imaged with the 3D MRI, and then positioned and sometimes repositioned a couple times, then a few hours have gone by. And then we do these treatments for 20 seconds with a 5-minute break in between. When we've done many treatments, like 30 or 40, we've shrunk our waiting time to 2 to 3 minutes typically. And we raster our treatments. So we move around the tumor a little bit so that we don't treat 2 cells that are adjacent, and maybe we give time for this area to cool down while we treat somewhere else in the tumor. And that allows us to shorten the time a little bit. But they are typically anesthetized for 4 or 5 hours, and they do really, really well in that time. They wake up nice and quick, and they are home that same night, so they don't stay in hospital. Not sure if that covered most of the question, which I can't see, unfortunately. Oh, here it is.
I think so.
Can't see it.
I can repeat the second part of the question. It says, when might you use percutaneous cementation of the defect after HIFU?
So currently we're not using cement injections. There are some colleagues, one in particular out in California. There are other folks who are doing that. We're not using this because we're really trying to look at HIFU, but it is an option. And I know in people, especially with vertebral lesions, I know they use cement injection a lot. And this is possibly an option to try and strengthen that bone. With HIFU, the research that is out there has shown that usually at 2 to 3 months, you do get a good strengthening of the bone, and some bone, I don't know, regeneration is not the right word, but some bone matrix that seems to return. And so our hope is that we actually, over time, if we can keep them from fracturing in that initial period, would gain some bone strength, because it does keep that structure intact of the mineralized bone.
There's another question in the chat. It's just asking, can you explain the difference between HIFU and histotropy? Sorry if I said that wrong.
Thank you. Um, Thanks, Max, for that. That's a hard one. Histotropy. So so HIFU uses heat. It converges those sound waves and creates heat to burn the tissues, whereas histotropy uses cavitation, or sort of that micro bubble type action, where it creates this cavitation and micro bubbles that form into the tissue. And those, if they reach a certain point, they explode, they implode actually, and that will create micro shock waves and then kill tissue around the area. So it is another technique that's used. It uses the same principle of ultrasound as the base. And there are some folks out in Virginia that are studying that for osteosarcoma in dogs as well. And so it's just a different type of treatment. Some folks claim that, the histotropy maybe is less contained or controlled, because you can't necessarily control what shocks where, and so therefore HIFU may be slightly more precise, but the techniques are completely different. So if we're using HIFU with MRI, obviously it needs a very expensive set of equipment and people to run it, and it may be more precise, but it's more unavailable to the masses, versus ultrasound may be more available. And then you can do either your ultrasound guided HIFU or your ultrasound guided histotropy for treatment. So they're just different things that are being looked at this point, and hopefully some good results come from any or all of these studies.
Can I actually follow up to that question with just even broadening that out a little bit on, and I know this could be a very long answer, but just giving us a little bit of like differences of the different types of ablation techniques, because cryoablation or radiofrequency ablation, and are there any kind of things about each that make it more useful or relevant for canine versus human disease?
Yeah, so in dogs, we don't use, some folks are studying things like microwave ablation and radiofrequency ablation for some tumors, especially some descriptions of radiofrequency. I'm having difficulty, radiofrequency and microwave ablation in lung tumors. And those are done with a probe that you essentially insert either percutaneously or through an open incision into a tumor, and then it expands these little antennas essentially within the tumor and then burns. So those create heat as well, just in a different manner, and they do require an incision or at least a puncture to then get into the tumor. So in veterinary medicine, the majority of them so far have been done open. I saw several of those during a sabbatic at a human hospital where they were done percutaneously for some of the lung tumors or metastases. And so, but still somewhat invasive. The cryoablation obviously uses cold. Cryoablation has come in and out of favor for various tumors and various reasons. Again, the cryoablation maybe is slightly less controlled because you create this cold ball, and I'm not a specialist in any of those, the radiofrequency, the microwave, and or the cryoablation. It's not really my area, but the ice ball that you create, you hope that it cools enough, and then that when it thaws, it causes some cell damage. And typically you would freeze and thaw a few times to try and create that cell death. But it is potentially less controlled as well. Now, that can probably be said of histotropy and HIFU as well, because, we aim to treat this area and we heat, and sometimes we get a bit more than we wanted or a little bit less. We kind of learn as we treat with our test shots whether or not we're going to heat a lot or a little, and then that guides how big of an area how big of a cell we might choose, and how high of our energy will be for our treatment, so that we try and keep it safe for each of those cells we treat.
And there's another question in the chat that's asking, do you use a tourniquet for the distal radius tumors?
So we don't use a tourniquet. I think I guess the concern could be, I'm assuming the question relates to the heat sink effect. So if you have too much blood flow in an area and you try to heat it, then the blood may cool down the area. The vessels are pretty small in the area that we're treating, and we do not use a tourniquet. We don't seem to have a need for it. And it would be a long time as well. It would be concerning for us to keep that on for those long periods of time.
And there's another one that's asking, do you see the main benefits of HIFU for palliation or for anti-tumor effects?
So it's an excellent question. So palliation or anti-tumor effect. Currently, hopefully both. I think for dogs, definitely palliation, because these are patients who otherwise cannot get the standard of care. They could potentially get a limb spare surgery and chemotherapy, but the owners typically have ruled that out and they're looking at radiation or this novel technique. And it seems to be providing palliative pain control, at least for those patients. I do really believe, and based on what's published, and I hope that we can also reach an anti-tumor effect, an abscopal or distant effect from the tumor that we treat. It makes sense if we burn the tumor and leave it in situ, and the immune system can build an immunity against it, that potentially it could help with that. We don't have enough data currently to show that. There's things we're looking at doing with looking at immune cells in the blood before and after treatment to try and see if we can document some of that. And definitely some of our colleagues at other institutions have started doing some of that and found some promising results. It's a hope, and that's why we still also are potentially offering this study to people who want to try the HIFU, maybe wait a little bit, give it, a few weeks, and then go for amputation. So you do delay your removal of the tumor, which, maybe is a negative, but we don't know what the positive could be with leaving the tumor in situ and building that immune system hyperactivity a little bit, so that maybe you can suppress your metastases.
I was also just going to ask how long, but it sounds like it's still being studied, how long we think that abscopal effect lasts, like what the window is, the benefit.
I don't know that we know. We don't know quite. It seems like it takes a few weeks to develop, and but we don't know how long it lasts. At least I
And the
don't.
next, oh yeah. And then the next question from the chat is just asking, what's the biggest technical limitation of magnetic resonance HIFU and that you would like to see addressed?
If I had a way of addressing, there would be two things. So one, we get excellent images with MRI, and we see our treatment for each of the treatments, but we can't get, it seems, an image of this is my 3D tumor and this is what we've managed to treat. So I would love to be able to see that. I think that would be really helpful while we treat. The other issue is the positioning for dogs. And so I think for humans, it's probably easier. You ask them to position themselves properly. For dogs, especially with the distal radius, it's very difficult to get them in a position where they'll fit in the tube and we can get really good contact with the gel pad without causing them to be contorted and potentially uncomfortable after the fact. So having something that's a little less in the table and a bit more applicable to the patient, rather than having to put the patient to the table, then putting the HIFU to the patient would be much easier. And some of the more portable systems have that option. The system we're using is in a table.
Does putting the gel pad in the magnet MRI while you're imaging, does that help control the bias towards the tumor, or do you think it's more difficult to target all of the ultrasound rays towards the tumor if you're in the MRI?
Sorry, I'm not sure I understood the question.
Is it like easier to image in the MRI, or is the only advantage of doing the HIFU and the MRI just to get imaging of
Oh,
the
Great
the
question.
tumor.
Yeah, so the MRI gives us great anatomical detail of the tumor. It can tell us where nerves and vessels are and where areas where it's going to be difficult to aim because there is still mineralized bone. So it's really excellent in that way. And it also provides the thermometry, which is fabulous because then we can really feel safe doing these treatments that we see the temperature change in real time, just a few seconds delay, which gives us that confidence that, okay, we've treated, it was effective, it went up enough to be in that red zone, and the tissues around it were not heated, so we can go ahead and do another treatment close to there and it should behave the same way. So that's the huge advantage of the MRI system. Which is very important, especially right now as we're starting and we want to do no harm. We really want to help those patients and get good success for them.
Can I back up a little bit to one of the last questions you answered about, what kind of what your kind of wish list would be for any overcoming any current limitations. So it sounds like you could use a standard MRI machine. Because I think one question I was wondering, like, how difficult would it be to kind of access this type of treatment? So it sounds like you can use a standard MRI machine, though there are these devices where you can, you're not limited by kind of contact on the pad, right? Because you can.
Right. So the unit that we're using is made by a specific company, so that MRI and that HIFU table communicate, and it's all sort of integrated. But there are other systems and some homemade systems that people have developed over the years, from what I understand, that could be more portable. And I'm sure that there's other technologies being developed all the time to try and ease that. Certainly, if you had a portable HIFU and an MRI, then yes, you could do that. But then to have the thermometry, I believe you have to have the system that speaks to the table and the MRI speak to each other.
Right, gotcha. And so what would be, I mean, because it sounds like there's certainly, in the example, I think was it George, where he definitely had some palliative effect, but you just couldn't reach the entire tumor. And so what is the ideal depth, I guess, and also even just tumor size where you could have the best ablative effect, where you're actually able to kill the entire tumor?
Yeah, great question. Currently, we're trying to limit it to tumors that are 5 centimeters or less. We've treated bigger, as you saw in some of those images, but the smaller, the better, because then we can treat more of the tumor area. But in people with metastases, they don't necessarily try to ablate the tumor. If it's for palliative pain management, their goal is actually to kill more the tissues around the surface of the tumor, the periosteum, because that's where the pain comes from these nerves being stretched and irritated. And it seems like treating the surface of the tumor in those cases, if we're not aiming to kill the tumor itself, then seems to work well for palliation. So for George, given we only managed to coagulate or kill a portion in the center there, I think our belief is that his palliation of pain was really related to reducing that pressure and the irritation on the periosteum, and hopefully affecting kind of that denervation in the area of periosteum. And then other dogs, like OJ, for example, he still has that fissure down his bone. And when you touch his leg now post-treatment, he's comfortable all over his tumor except where the area of that fissure is. And so hopefully we've palliated some of his pain, but his fissure is still active. We're hoping that, in weeks to come, that as the tissues remodel, perhaps that remodels as well, and maybe that will improve, and that it doesn't go the other way and, in fact, fracture through his joint instead. That area was very difficult for us to access, and I'm not even sure that we would have been very comfortable, obviously burning the tissues right there, knowing that there's a fissure.
Squeezing one last question before we let you go. Is a dosage max? I mean, aside from like dose limiting toxicities like the burn, the poor burn that he had, but so for example, like for radiation, right, you're limited somewhat by there is like a dose limit. And so is that an issue? And is it more, I don't know, I mean, I guess there's also less time, but what are kind of the limitations there?
So the time, again, the length of treatment, it doesn't seem to be an issue if the patient is stable, and most of them don't have many comorbidities or anything. They seem to be very healthy otherwise. So that's not an issue. Unlike radiation, obviously there's no radiation exposure, so that's not a limitation. And there's no cumulative dose, that's a problem. So you could theoretically treat and retreat as long as you still have tissue to treat and that it's safe and you don't affect any important structures like nerves or vessels. So currently we do a single treatment initially, and then if the owners are willing, then and there's still growth or they've seen improvement and then maybe a relapse, then we are willing and considering second treatments in cases where we've seen some responses, and there seems to not be a limitation to that based on the literature.
Fantastic. Well, thank you. We're already at the end of the hour. This was so fascinating. Thank you so much for the overview, and put some links in the chat where you can find more information about the study. And also, if you know anyone who might be interested in enrolling, since it's ongoing. Thank you so much, Dr. Brisson, for joining us on OsteoBites today and for making it better for canine osteosarcoma patients, which will also help our pediatric patients. And more information on this and all OsteoBites can be found on our website, on our YouTube channel, and at your favorite podcast place. Next week on August 29th, we are going to be joined by Dr. Ellie Berry. She is the Chief Medical Officer at Day One Biopharmaceuticals, and she's also the co-leader of the Accelerate Fit for Filing Working Group. And she's going to be joining us on OsteoBites to share best principle guidelines and also defining elements of a data package for filing, roles and responsibilities in collaborative studies, as well as resource needs to operationalize and deliver these types of trials. And you can find our OsteoBites lineup for the next few months on our website. And if you have any ideas for topics that you'd like to hear about, please feel free to email us at events@mnbagents.org. Thank you again, Dr. Brisson and Max, for joining us today. And thanks to all of you for making time in your day and spending with us. We hope to see you back here next week on August 29th when we chat with Dr. Ellie Berry, and hope to see you soon. Thanks so much, Dr. Brisson.